of pediatric pancreatitis. Veronique, you may need to stop sharing. Yeah. There we go.
So thank you so much. I firstly wanted to thank CAPER for inviting me to speak. We're totally changing shift in topic and focus and depth, but I hope I'll be able to give you a bit of an overview about the pediatric world and how pancreatitis can be a very important part. And I hope the work that has been done to date will inspire people to continue further work. So firstly, I have no disclosures to make, but obviously I'm going to be focusing on children and primarily clinical care and primarily North American clinical care. So I wanted to get people started to think about pancreatitis and how it might come about. So case presentation, you're in the emergency room, 3.5-year-old comes in with, he's been having a day, abdominal pain, doesn't want to eat, he's vomited a few times, no fever, but attends daycare. Of course, yes, okay, we're in a presentation about pancreatitis, so you might think about it, but normally you might go, oh, it's a gastro, it's nothing, let me not worry too much about it. But what if the mom then tells you she has chronic pancreatitis and she's worried her son has pancreatitis? I think then anybody would kind of shift their focus and wonder, could this be pancreatitis? And it will change what you're going to do, most likely. The interesting part is that pancreatitis field in pediatrics has greatly advanced in the past couple of decades. I'm just going to go through actually some of the work that's been done to put down the field and try to get things that we speak the same language. So firstly, talking about definitions, I'll spend most of my time talking about acute pancreatitis, clinical management, how it presents, what we can do about it, and chronic pancreatitis to touch upon medical, endoscopic, and surgical considerations. So the first thing that I wanted to talk about is that primarily historically, people have done what adults have done, but really we have to look as children as their own entity. And so about 10 years ago, a group was formed, which is called the INSPIRE Consortium, which is the International Study Group of Pediatric Pancreatitis in Search for a Cure. And we came together to try to put together some definitions for pediatric pancreatitis so that at least going forward, people that would be studying pancreatitis would be speaking the same language. Of course, the interesting part is that based on our first presentation, we saw how difficult it can be to define things. So this might seem a bit artificial, but in order to do studies, particularly in a field that's not been well developed, one really has to come up with very set definitions. And they absolutely can be used in a clinical setting, but they might seem a bit restraining in a clinical setting, but they're very important in the context of research. So acute pancreatitis primarily will be the entity that most people in the audience will see in their clinical practice. And we really use the adult definitions to bring about what we would say for children. So first, abdominal pain that would be compatible with acute pancreatitis. And it tends to be acute in onset, tends to be in the epigastric region, and can radiate to the back. But interestingly, most young children do not describe that. Some teenagers will describe the radiation to the back, which is more what the adults might describe. We ask for serum amylase and or lipase at least 3 times upper limits of normal. There's many labs now that will run only lipase, but it's actually not been shown that for young children in particular, that lipase on its own is enough to make a diagnosis. And it's not known with the development of the pancreas that perhaps amylase might be a better marker. So we try and tend to get both. And we wanted a certain above limit of normal because there are other conditions that could cause an increase, and even an enteritis could cause a low level increase. Chronic renal failure can cause low level increase. So the further up you go above limits of normal, the better chance you have that the source is indeed the pancreas in the context of where your pain is. And third would be imaging findings that would be characteristic of acute pancreatitis. And for most children, the initial imaging will be by ultrasound, but once in a while, people might have a CT, contrast enhanced CT, EUS, MRI, MRCP, but most of the time it will not be what they would be getting initially. And we label pediatric onset as less before the 19th birthday. Acute recurrent pancreatitis would be having more than one episode of acute pancreatitis. And you'd like that they're very distinct, separate episodes, because an acute pancreatitis episode could be complicated by a number of fluid collections that could take months to get better. And we have found that children that have acute recurrent pancreatitis are become a very special group on their own that we worry about becoming chronic illness. And so knowing whether someone's had more than one episode is actually quite important. And ideally, you have complete resolution of symptoms, complete resolution of blood tests that they normalize. But obviously, you can imagine that for some children, at times, it's difficult to keep getting repeat blood tests. So the ideal situation, primarily in a research setting, is that you would have at least a month pain-free in between episodes if you didn't repeat tests, or you resolve the pain and you had normalization of your tests in between. And as I mentioned, in real life, it's not always followed. And then chronic pancreatitis. And it's very interesting. I was listening to the prior presentation and all the subtleties that one might have in trying to make this very early onset chronic pancreatitis. Is it reversible? Is it not? Well, when you're dealing with research and when you're dealing with children, you almost want it to hit you on the head that you're quite certain that someone who have chronic pancreatitis before you would label them with this. And obviously with children, we try to be least invasive, and a lot of technologies involve sedation or would involve rather invasive measures that we try to avoid. So at the time, we had labeled chronic pancreatitis that we would like one of three situations. So either one had abdominal pain that would seem to be emerging from the pancreas and imaging findings that were quite suggestive of chronic pancreas damage, that someone might have exocrine insufficiency, and it could be diagnosed through means that were mentioned in the first presentation, such as fecal elastase, which is frequently used in children, and suggestive pancreatic imaging findings. And I'm putting in the brackets careful cystic fibrosis, because obviously for children, someone might present with exocrine insufficiency primarily, and they never had acute pancreatitis, they never had chronic pancreatitis, it's just their pancreas didn't work. So this, in pediatrics, it becomes much more relevant to know what the background was. And thirdly, even though exocrine insufficiency typically comes first, that someone could have endocrine insufficiency first and then suggestive pancreatic findings. Obviously, it is much rarer to have pancreatic tissue available, but if someone had compatible histopathology, obviously this would be another way to diagnose chronic pancreatitis, as is more frequently done in adults. And the imaging I mentioned again might be a number of different cross-sectional imaging. It's typically not just going to be ultrasound by the time you label someone with chronic pancreatitis. But now, so we have definitions. So what do we see clinically in children? And we go back only a couple of decades, to be very honest. And it was a Sentinel publication about 20 years ago from a single institution. And what was relevant about it is that it showed that pancreatitis, acute pancreatitis, was diagnosed in children, and it was being more frequently diagnosed as the years were passing. I was lucky enough to spend some time with a wonderful team in Pittsburgh. And at the time, we had decided to look at also our evidence or experience in the Pittsburgh area, and also looking at the catchment population of children in Pennsylvania. And we showed a similar trend of increase for acute pancreatitis. And we were able to put more of a number for incidence that went from 2.4 to 13.2 per 100,000 children over roughly a 10-year period. Interestingly, more diagnoses were being made also partially because people were ordering more lipases and amylases. So obviously you have to think about pancreatitis. The little vignette I showed you at the beginning, you might not have thought about pancreatitis with the very first couple of lines, but once you got put in the context of a family history of pancreatitis, of course someone's going to think about it and you'll order it. So that was greater awareness. It's been partially responsible for the increase, but we do also think there's been a definite true increase. And how do children present clinically? Well, typically they'll come with abdominal pain, epigastric tenderness, nausea and vomiting, very characteristic symptoms that you would expect. But a toddler might have a hard time telling you what they're feeling. So you have to have a high index of suspicion, especially for younger children who might not be verbalizing it the same way as we would expect. With respect to etiologies, traditionally adults, we've primarily thought of biliary and alcohol as being very prominent cases. In children, obviously, alcohol is a much less prominent reason, and even biliary, although there are certainly teenagers with a gallstone disease of different ethnic backgrounds, and as body mass indexes are going up in society generally. But there's a whole slew of different pathologies that might be responsible, including a number of anatomic malformations that someone might be born with, more multisystemic conditions such as someone having hemolytic uremic syndrome or Hinoch-Scheinlein purpura, or even COVID has been found to be a cause of acute pancreatitis in both children and adults. And a large portion used to be called idiopathic. About a quarter of cases used to be. But as we're becoming better to identify genetic predispositions, we're realizing a lot of the idiopathic cases are actually related to genetic predispositions. And as an example, this is the INSPIRE consortium, and this was our first our first data set of children. And at the time, we were just collecting what physicians had collected on a clinical basis. And the 4 more common genes that were being tested for at the time, CFTR, which is for cystic fibrosis, PRSS1, which is cationic trypsinogen for hereditary pancreatitis, SPINK1, and CTRC. And the very important and very noticeable finding is that almost half of children in this cohort that was selected for acute, recurrent, and chronic pancreatitis, almost half had a genetic predisposition for acute pancreatitis, and almost 3/4 in the chronic pancreatitis. And that just goes to underlie the dramatic involvement of genetics in children. And the genetics also has an involvement with respect to what happens with the natural history in the clinical course. And this was a publication from the group in Cincinnati a couple of years ago that showed that the more genes that you had, the faster a child might progress from first presentation of pancreatitis to chronic pancreatitis. And the involvement of genes actually also made it seem that the progression to chronic pancreatitis was faster than if someone had different etiologies. And this is actually quite striking and important in the thought process of children with pancreatitis. Now that I've talked a little bit about how children might present, obviously another question is, how bad is it? And when you work in a field that's not been well developed, you start to learn that there are many things that you could publish to hopefully help make things be more congruent with each other so that different people are speaking the same language. So I was also involved with NASPGHAN, which is the North American Society of Pediatric Gastroenterology, Hepatology, and Nutrition, to come up with a classification system for severity. It's very difficult to know how badly someone's going to be. But what it seems to be both in adults and pediatrics is that it depends on how inflamed your body is. And there's a certain amount of systemic inflammatory response syndrome that will actually lead people to be sicker and be more likely to end up in the ICU and potentially die versus people who don't mount such an acute systemic inflammatory response. And a lot has to do with organ dysfunction and how long organ dysfunction lasts. So if someone's organ dysfunction, and that could be cardiovascular, renal, or pulmonary, lasts for more than 48 hours, they tend to be more sick. And so this classification was also led so that future publications could look into this to see how sick their cohort was. Of course, people have tried to also figure out when people are presenting in your emergency room how sick they will be. And this, unfortunately, is more difficult. And a lot of people will look at things such as white blood count, calcium, BUN, albumin at baseline and at 24 to 48 hours. But unfortunately, you need a little bit of that time frame to decide how someone's going to be sick. But if they're having organ dysfunction, that would be the kind of person that you might be more worried and put them in a higher care setting, or potentially transfer if you're not a center that's very used to dealing with sick children. And I think what more importantly has come out, and this was a publication from about just a little over 3 years ago, is how can we optimize what we do with these children? And this was a mostly expert panel consensus, because there's actually very little literature and evidence base out there. But again, this was to help put the field forward, and hopefully that in a number of years, we can improve upon these recommendations, that they be more evidence-based. And we went through a number of things to help guide people. And I would recommend that anybody who's interested, please refer to some of these documents. So we went through the diagnosis, and we already went through it already. And that often it is worthwhile to do both liver enzymes, triglycerides, and calcium levels in someone who's coming in with a first attack of acute pancreatitis, because you may find things that you can do something about. Fluid resuscitation seems to be very important, and is a bit unclear whether Ringer's lactate is superior to normal saline, but clearly the pancreas needs to be well hydrated, and someone who is dehydrated, poorly perfused, will have a more severe clinical course. So hydration, urine output, and watching, and usually 1.5 to 2 times maintenance. Obviously in children, everything is based on body weight. So it's not just, I'm going to give 1,000 milliliters per hour. You have to look at the body weight of the child. So boluses and maintenance fluids are based on this too, but someone needs to be well hydrated. And so particularly in the first 48 hours, watching for people, watching for organ dysfunction, watching for urine output, ensuring that they're well hydrated is quite key. And pain management can also be quite challenging, particularly for young children. And so having an acute pain team, having someone who has expertise in this may be invaluable. You don't want someone to be so uncomfortable that they're not going to want to drink, they're not going to want to hydrate if they're wanting to. And you might need acetaminophen, NSAIDs, morphine, and other narcotics to help manage the pain. Nutrition has become known as one of the key components of the management of acute pancreatitis. And really, it's now been understood, and there are pediatric publications, mostly single center, that it should be patient guided. If someone wants to drink, let them. People do better if they are not fasting. You do not want someone to be fasting for longer than 48 to 72 hours. There can be bacterial translocation increases. They tend to be sicker, tend to get more sepsis, more organ dysfunction, and more death. And it can be clear fluids. You can advance diet as they wish. If they do not want to eat, you can put an NG, NJ. There's no particular means that's better than the other, but just to get something in them. And you try to reserve parenteral nutrition for cases where you clearly cannot feed them, that it's a contraindication. And if as soon as you can use some kind of enteral nutrition, it's a benefit to just keeping them on parenteral nutrition. So this is a very key point I'd like you to take home with. Other points that we went through is that antibiotics often get overused, and it was a point of contention even within the expert panel, but most of the time prophylactic antibiotics should not be used even in severe acute pancreatitis. They really should be reserved when it is felt that pancreatic necrosis is infected. There's a number of things that people have tried in the literature, proteases, so antiproteases because you're activating proteases, antioxidants don't seem to have benefit or role at this point in pediatrics. There have been a number of trials using probiotics, and the Dutch pancreatitis group had published a very nice a manuscript a number of years ago that showed concerns that it could be increased problems by giving probiotics, so not recommended. Most of the time, children don't need an endoscopy. You're not going to be doing anything that's going to resolve the pancreatitis. It's very rare that someone would need an acute ERCP. It could be a scenario if someone has a stone stuck, so a cholangitis picture. Endoscopic ultrasound, really rare. Surgery, the main factor comes into play where people have biliary pancreatitis. And for a uncomplicated, simple biliary pancreatitis, before someone goes home, they actually should get their cholecystectomy. This has been shown that it reduces the chance of people coming back within the next 30 days, has even been shown in children, and that there are no negative more negative outcomes if it is done during that initial presentation. And obviously you have to follow children because there will be a certain percentage of children that will present again with recurrent pancreatitis. Now, if I segue rather quickly into chronic pancreatitis, this is actually a very important issue because the quality of life of children gets severely affected. And as was mentioned before, once you have chronic pancreatitis, it's probably for life. So you need to be able to manage it the best possible to improve quality of life. NASPGHAN has developed 3 joint papers that would deal with endoscopic management, surgical management, and medical management of chronic pancreatitis. This first one that was published had to do with endoscopic management, so EUS and ERCP. And I do believe Dr. Vitali, who is one of the authors on this manuscript, will be doing one of the presentations for CAPER in a number of weeks. So he'll be talking a lot more detail about this. The point of this publication was to show that they are maneuvers that can be important in chronic pancreatitis, but that there are certain considerations that have to be had because of the size of children, because of anesthesia. There are certain benefits and risks. As had been mentioned in the last presentation, ERCP is more as a therapeutic maneuver and it's not as a diagnostic maneuver. And at times, someone might need surgery, and the position paper will be coming shortly from NASPGHAN regarding this. But obviously, we try to be least invasive to more invasive when we can with children. Medical management of chronic pancreatitis is another manuscript that has been recently published that goes through in great detail how to manage children with chronic pancreatitis. And they do become very complicated. And this is where a multidisciplinary team becomes necessary. Quality of life becomes very important. Growth and nutritional aspects are very important. You have to follow children for the development potentially of exocrine insufficiency. They might need pancreatic enzyme replacement therapy. They can also develop the special type of diabetes called type 3C diabetes. And this becomes much more complex to deal with if someone has both exocrine and endocrine insufficiency and they're a child who has to grow. pain is probably the most important factor. And there's a lot of different therapies that have been developed, very difficult to manage, and usually has to have involvement of anesthesiologists and other pain specialists. Obviously, when a child is diagnosed with chronic pancreatitis, you can give them guidance about future avoidance of alcohol, cigarette, healthy eating, healthy weight, but this becomes much more relevant because they need to grow normally as well. And the quality of life and being patient-centered and family-centered becomes very important. As a final aspect is that what else can we do? So we can give information so that people have guidance about what to do. Because most people will see acute pancreatitis in their practice, a number of years ago, a number of centers that had developed some algorithms to manage acute pancreatitis at their centers came together to develop a workflow, an algorithm that would be proposed for people to go through. So when children would be presented to the emergency room, how do you handle them? You know, so that you make a diagnosis, you consider your severity, you might need to consider intensive care unit observation. You have to go through, what am I going to do with my fluids? What am I going to do with my pain? And what will I do with nutrition? And this is a nice publication that goes through, and perhaps some could be altered depending on people's institutions, but to keep you thinking about all these aspects of care. So I had the monumental task in my mind to give you a little bit of an overview of pancreatitis in children. I hope that through the preceding few slides, I was able to show that acute pancreatitis has been increasingly recognized and diagnosed in children. The etiologies are quite broad, and you have to think about them, and you have to think about genetics. And we tend to do a genetic workup if someone's had at least 2 episodes of pancreatitis, or if it's been acute pancreatitis, or 1 episode in a family history. And if I go back with my case scenario, that 3-year-old child that came with pancreatitis, the mother had a PRSS1 and he had a PRSS1 and CTRC mutations, which might be part of the reason why he presented so young. Our societal publications have tried to increase standardization so that we are speaking the same language when we diagnose, when we classify severity, and hopefully help guide management. And what we're trying to do is improve the clinical course and outcomes of children with pancreatitis. We've had much more recent work in trying to do the same thing with chronic pancreatitis, which is a much more complex entity, and trying to look at the endoscopic, medical, and surgical considerations. And really, it's to try to improve quality of life and long-term outcomes, as obviously these children might be living with this for decades. I do think implementation of order sets for acute pancreatitis can help and can be useful, especially for centers that are not very used to seeing acute pancreatitis or don't always have a pediatric pancreatologist, a pediatric gastroenterologist available. And obviously, we need to have more pediatric-based research, more pediatric-based publications, as children are not little adults. And with that, thank you so much.
Thank you, Veronique. Yes, you did have a monumental task of trying to cover all of pediatric pancreatitis in 20 minutes, so much appreciated for that wonderful summary. There is a question about the management of acute pancreatitis in the audience. Is there evidence for or against the use of a low-fat diet during an episode of acute pancreatitis in children?
So it's very interesting because we tend to, I think, naturally speaking, I still tend to do this, right? You get them to use clear fluids, and then you progress to low-fat diets, and then you'll progress to a regular fat diet. But there's actually been a few publications that you could probably start with a regular fat diet, and it doesn't seem to increase pain, doesn't seem to increase length of hospitalization. I think the key is just getting them to have something, actually, is really the key, so that they're not fasting. So if you feel more comfortable, and often even the patient is going to be a bit more tentative initially, it's rare that a kid will come in with pancreatitis and want to have a hamburger within 3 hours, but they're going to tell you, I want juice, I want juice. And I think and it's still the default of the emergency room, NPO. And it shouldn't be. Yes, they might need to be NPO if they're going to get imaging, but it shouldn't be. And it should be if the child wants, and it's been shown, I think it was a publication from Nationwide, that if they let the children decide, the patient-centered, the patient-guided, the children stayed less long than if they let the medical team try to decide, oh, when is the pain okay that you can have? So really, you should let, if the child wants to eat, it's probably a good sign that the inflammation is not so severe. So there is no strict evidence for low-fat diet. And I didn't have much of a chance to talk about acute recurrent pancreatitis, But in a similar vein, the difficulty is that children need to grow. Children need to gain weight. Children need to have a certain amount of fat in their diet to do this. It's tempting to say, okay, if I put them on an ultra low fat diet, maybe I'm going to prevent attacks of acute pancreatitis from occurring. But there is no evidence at this point. I'm not saying it's impossible that there wouldn't be evidence, but at this point, there is no evidence for that, nor is there any evidence that giving children pancreatic enzyme replacement therapy without exocrine insufficiency will do something to prevent attacks of acute pancreatitis.
Well, that's wonderful. Already you're speaking to some of the differences between adults and kids. The adults won't ask for juice, they'll ask for beer. The adults need to lose the weight, so a low-fat diet regardless is probably what they need given the obesification of our society. A few other quick questions, and I may have missed this. You had mentioned that there does appear to be a true increase in AP in children, and what is your suspicion as to the etiology? And you presented the number of etiologies. Why do you think there is a true increase as opposed to just physician perception?
So obviously genetics is not going to change that much. One would consider potentially medications. Certainly we are, there's a number of anticonvulsants, there's a number of anti-neoplastic medications that are clear-cut, a number of IBD medications. So we are using more medications generally in children. So that could be one aspect that could definitely go up. In certain countries, handlebar injuries, things like that are more problematic. So there could be external factors. Certainly there are children who, well, mostly teenagers who drink alcohol. We even wonder secondhand smoke has some effect on pancreatitis also. So there might be more of these environmental factors that could come at play. I do think there certainly is a component that we're looking for it. And that's what I was alluding to when I was talking about my time in Pittsburgh, because we had looked, and certainly as the years went up, there was quite a correlation. Didn't explain all the cases, but there was quite a correlation with looking for it. So you look back 40 years ago, the kid vomiting, upper belly pain, they'd say viral gastro, would never test the lipase. In 2020, you test the lipase, wow, this kid is acute pancreatitis. So I think there is a certain element of that also, awareness that it can happen even in young children. So let's look for it.
You have some other follow-up questions about how do you manage acute recurrent pancreatitis vis-a-vis imaging and lab. Can you make any comments?
So again, it was through Inspire. There's a publication that has to do with kind of causal evaluation. So we tend to throw more the book at children when they've had, often in my mindset, you have one attack, you do pretty well. Okay, we'll give you a pass unless there's something obvious that we can modify. You come with your second attack, I'm going to be a lot more concerned that there's something why you are getting 2 or more attacks. So we tend to be more aggressive with imaging. So if someone has not had cross-sectional imaging, we do prefer MRI, MRCP. So even if they're young and need anesthesia, we will typically offer that. We will tend to do a genetic panel. And there's a number of commercial genetic panels now that are testing, 5, 10, 12 mutations. So we tend to look at that. We will do a sweat chloride test because, CFTR is a very complex gene with probably more than 2,000 mutations. And really the function is important. You want to know if someone could have, in particular, pancreas sufficient CF, because they're the ones that could present with pancreatitis because they still have pancreatic tissue involved. And what we had suggested for Inspire is that you need to follow things over time because they can be subtle. At what point would someone develop chronic pancreatitis? So I tend to follow fat soluble vitamins. If I can manage to do it, I'm in Canada, so it's a publicly funded system. So I tend to do if the patients are willing, vitamin A, D, E, and coags once a year. I tend to do fecal elastase every year or two. Depending on the frequency of their attacks of pancreatitis also, to look for complications. I don't do an OGTT unless I'm really concerned, but I might do a flat fasting glucose and a hemoglobin A1C. So I'm looking for complications, and obviously I'm following their growth because that could be another hint that something is going on. So you're going to want to do repeat imaging. I tend to alternate MRIs with ultrasounds, especially for the ones that need sedation, to try to follow them over time. And I've had both extremes. I've had some kids that had 4 or 5 episodes within a year or two, never have again. And you have some that unfortunately keep having them. And we do think it tends to be a progressive process that then they end up with more classical chronic pancreatitis. So the key is to follow them so that hopefully you could intervene at least nutritionally when they need it.
Is there a role for biopsy, particularly in settings of idiopathic pancreatitis, negative genetic testing? Where does that fit in tertiary management?
So the only time I've ever sent someone for biopsy is for an entity that we didn't really talk too much about with his autoimmune pancreatitis, which is a very rare entity in children and can present actually more with a chronic pancreatitis picture and at times both exocrine and endocrine insufficiency, occasionally with an acute pancreatitis picture. That for me is a good reason to want to get tissue if I'm not sure what's going on, because for that entity, there are certain criteria that are adult based, and it becomes difficult because children do not tend to have this high IgG4 type disease, this type 1 acute autoimmune pancreatitis. They tend to have this type 2, which is more pancreas based. If I find an IBD, okay, I'll think about it and maybe I won't get tissue because then it makes clinical sense. But I would say for us, that'll be the primary reason. The second reason is that if you seem to have, and often it's the context of autoimmune pancreatitis, of kind of a pancreatic mass, and you want to make sure it's not a neoplasm. Again, not very frequent, but it happens occasionally. I don't do EUS. We actually ask our adult colleagues that there's a few that we have. And this is an important point for a lot of centers. They don't have pediatric EUS providers, that you make a nice collaboration with adult providers that can become comfortable to do your pediatric patients so that they can be doing the EUS and the biopsy and they're comfortable doing it. So those would be the two scenarios that for me, we normally would not do a biopsy to make a diagnosis of chronic pancreatitis. I would say we would try to go more globally just because it is, we feel it's quite an invasive procedure and we want to avoid complications from it.
Well, thank you, Veronique. You generated a lot of interest and questions and a lot of positive compliments. So thank you again for being a part of kicking off this wonderful series. We have, to the audience, we have several more pediatric related lectures in the forthcoming series. And I want to thank everyone for spending this evening with us. And I look forward to seeing you all next Thursday. Thank you.